Hi, and welcome to Hughes Knows Nursing. I am Veronica Hughes, and today we are going to talk about right-sided heart failure. So, in the last video that I did, we talked about left-sided heart failure. You've got two sides of your heart, and so the left side is the most common side to fail, but sometimes the right side can fail as well. So, the patho is the same. So the right ventricle, instead of the left ventricle, this time it's the right ventricle that's not pumping correctly or effectively. So when that right ventricle doesn't pump, then it's not going to move blood forward to the lungs, and then you're going to back up. So where do you back up if you back up from your right side of the heart? Well, if you remember, it's the venous circulation that comes back into the right side of the heart. So you're going to back into the body or the venous system if the right side of your heart is not working correctly. So that means tissues, organs, that kind of stuff. So left-sided heart failure can cause right-sided heart failure, and it's the most common cause of right-sided heart failure. Also, pulmonary problems like pulmonary hypertension would be a cause of right-sided heart failure, or fibrosis in the lungs, such as COPD, sleep apnea. Smoking can cause right-sided heart failure. Also a condition called cor pulmonale. So cor pulmonale is the right ventricle gets dilated, and hypertrophy. So it's like it's been working out too much. The muscle wall gets really thick. It's a result of any kind of lung disease or disease of those pulmonary blood vessels. So right-sided heart failure signs and symptoms. So JVD, jugular venous distension. So those veins that go up, they're going to be like bulging, which is not normal. You don't want bulging neck veins. Then you have ascending dependent edema. So it's going to start low and it's going to go high. Okay, so we're going to start at the feet and the legs, ankles, and then it can continue to progress up even into areas like the sacrum. Okay, which is pretty weird to see and assess. You can get abdominal distension and ascites. Fatigue and weakness is really common. Nausea and anorexia. You're especially with all that edema, you're just so full feeling. You're not really hungry. And maybe feel a little bit nauseous. Nocturia, so you have to pee at night. Hepatomegaly and tenderness, so enlargement of your liver. Actually, right-sided heart failure can cause liver failure. Who knew? So enlargement of the liver, which you can palpate. And then weight gain, which makes sense because we're backing all that fluid into edema. And so we're going to do interventions like daily weights and things like that to measure that. All right, let's do a little comparison of right versus left. So tell me if you think this is a sign of right-sided heart failure or left-sided heart failure. Weakness. Weakness is actually left-sided heart failure. Jugular vein distension, JVD. That's right. What about dependent edema? Legs, sacrum. Also right. Hacking cough, worse at night. Remember that? It's left-sided heart failure because it's backing up into the lungs. An enlarged liver or spleen, backing into the system, so that's going to be right-sided heart failure. Exertional dyspnea. Remember lungs, so that's going to be left-sided. Distended abdomen, backing up into the system, so that's going to be right. Weight gain. Weight gain is going to happen with right. An S3 or S4 gallop. That's actually left-sided heart failure. And then crackles in the lungs. Crackles, lungs, left-sided heart failure. So if you're very unlucky, you can have right and left-sided heart failure, which is called biventricular failure. It's neither ventricle is working adequately. As you can imagine, it would be problematic. You're really not going to feel good. So all the symptoms you had with left and all the symptoms you have with right, you're going to just throw them all together. So you're going to get buildup into your lungs, and you're also going to get some systemic buildup. Pretty common to have left and right-sided heart failure. And you're going to have decreased perfusion to your organs, but you're also not going to get that excess fluid back up into your heart to go through the system, so you're going to have edema. So these people feel fairly rotten. Now let's talk about some complications. Pulmonary edema is one of the most dangerous complications we have of heart failure. So pulmonary edema, you've got this backup of fluid into the lungs, so your alveoli are filling with fluid. And so you're going to have signs and symptoms of respiratory distress. So they're going to be anxious, right? Because they're not oxygenating well. Pale and cyanotic. We're not getting good perfusion. They're going to be dyspneic, which makes sense. Lungs filling with fluid. Or orthopnea. So if I lay back, I'm going to feel more short of breath. Tachypnea. I'm going to be breathing fast because I'm trying to exchange gas. But I can't very well because I've got that fluid that's kind of blocking those alveoli from being able to do that gas exchange like they should. Paroxysmal nocturnal dyspnea. So more short of breath at night. I'm going to use accessory muscles again in an effort to help with that gas exchange. Then you have that pink frothy sputum. Remember, we get crackles when we have fluid in our lungs. Tachycardia. So our body again is trying to compensate for that hypoxia, right? They're going to be hypotensive with their tachycardia. So usually when you have hypotension, your body's going to respond with tachycardia. You can also be hypertensive, depending on how stable you are, how far you are in the progress of your edema, your pulmonary edema, what your baseline status is. So hypotension or hypertension, it would be really nice if it'd just be cut and dry and be one or the other, but body's complicated, turns out. Then you're also going to have those abnormal S3, S4 sounds. So S1 and S2 are your normal heart sounds. S3 and S4 are going to be abnormal. So if you see something about an S3 or S4, that means that's not normal, and that should be a red flag. So diagnostics for heart failure. How do we determine if somebody has heart failure or not? So we always want to figure out what the underlying cause of the heart failure is so we can address it and then help regain some function if at all possible. So an echo is the most common thing that we do, an echocardiogram. It's going to check the ejection fraction of the left ventricle. It's going to check the movement of the heart valves. It's going to tell us if we have a clot or something like that happening in the heart that could be contributing to everything. EKGs are going to tell us about the electrical activity in our heart, to tell us if we have an arrhythmia or something like that. They will be on a cardiac monitor, just so we can look for those arrhythmias. Chest x-ray, it tells us about our lungs and our heart. Tell you about the size of your heart as well. Cardiac stress test will let us know kind of what our heart will do if it's put under exertion. So it will tell us if we have any problems with like coronary artery disease or something like that. You can do a heart cath, so a heart catheterization, where they go in. That can tell you your ejection fraction as well. But it also can tell you the health of the coronary arteries. And then a BNP. BNP is going to be elevated in those that have heart failure. The normal labs can be a little bit different depending on what lab you use, so just check whatever your references are for that number. But BNP is the thing that's going to be elevated for heart failure. So that's it for now. So we talked about right-sided heart failure, we talked about biventricular heart failure, we talked about some pulmonary edema, and some diagnostics that we use to determine if somebody's experiencing heart failure. So hopefully that was helpful. If you have any suggestions, please let me know. Otherwise, happy learning.